Hello, professionals. This is Dr. Saad, and as you know, we are recording series of lecture for pharmacists who are going to appear for international equivalency exam. And our topic of discussion was endocrine system, in which we talked about female reproductive system, and there are some points of are missing. So let's resume our topic and complete its remaining point. So point number one is about a drug that is the mastranol, and it's estrogen, not a other drugs. So keep in your mind. Point number two is about the medroxyprogesterone. It's a progesterone, not a corticosteroid. Point number three is about some detail regarding androgen. As you know that ovary produces estrogen, which is responsible for appearance of secondary sex characteristic in females. Similarly, testosterone produces testis, which attributes secondary sex characteristic in male, and it is this testis also have endocrinic as well as gametogenic function, just like ovaries, and it is also used in case of constitution of sperm production, and for this purpose high concentration of testosterone is locally required to achieve this effect. So androgen is also used in certain conditions for androgen replacement therapy. I will just mention the name of that condition: in case of hypogonadal man, in case of gynecological disorder, in case of protein anabolic agent, in case of anemia, in case of osteoporosis, in case of growth stimulation, and in case of anabolic steroids. And it is also used by a sportsman, or in other words, we can say it is also abused by a sportsman to increase performance. It also used in case to delay or to prevent the effect of aging. So these are the implication points for androgen. There are some preparations that is used in androgen replacement therapy. Its examples are: number one is methyl testosterone, and it's available in case of in dosage form of oral as well as sublingual. Its dose, which is recommended, is 25 to 50 mg per day. Similarly, fluoxymesterone, its dose is 2 to 10 mg per day. And testosterone anathate, it's available in the dosage form of intramuscular, and as you can see, it is administered intramuscularly. And lastly, that is the testosterone. It is available in the dosage form of gel. It is recommended TDS, and its dose can be start from 5 mg to 10 mg per day. But with respect to situation, its dose can be reduced from 2.5 to 10 mg per day. So if you use this androgen replacement therapy in a long term, then it may cause hepatic carcinoma, edema, and testicular atrophy. So this was all about some points relevant to androgen. So next, point number seven is about the home pregnancy test. As you know that Werner-Chilcot assay is used for the detection of the presence of HCG. As you know that it is an human chorionic gonadotrophin, and positive dark line donut shape brownish ring in this tube. This is actually through this Werner-Chilcot assay we detect the presence of HCG, which is also known as human chorionic gonadotrophin. Its presence is detected in the form of line that is known as donut shaped brownish ring. So through this way, home pregnancy test perform its functioning, and presence of pregnancy is detected. This was all about point number seven. Point number eight is about, as you know, that follicle stimulating hormone is responsible for increase in the production of estrogen. Similarly, luteinizing hormone is responsible for production of progesterone, or you can say LH increases the production of progesterone, and FSH increases the estrogen production. And as you know that estrogen is secreted from ovarian follicles, and its level can be controlled by, you can say, FSH and LH reach at higher level during ovulation, and FSH is controlled by the blood estrogen level. So as once you revise the mechanism of menstruation, so menstrual cycle, then you will see that estrogen high increase the level of estrogen in blood gives negative feedback to the production of FSH. So its level of FSH is controlled by the estrogen level of blood. So as you know that this was all about our point number eight. Point number nine is about the breakthrough bleeding. As you know that it's an unscheduled bleeding occurring between the period during pregnancy, and it is typically small spotting as well as some may experience heavy bleeding, and it is often happen due to ladies who smokes or who don't care about their birth control pill. This breakthrough bleeding cases happens often in those ladies. Point number eight is about again about the estrogen. That is, the excessive estrogen stimulate the endometrium to proliferate, and it is in an undifferential manner. So it may cause a condition that is known as endometriosis. Endometriosis is a condition in which mistakes like bleeding occurs, and you can say menstruation like bleeding occurs. Similarly, there is a side by side cases of pain and inflammation, and it is treated by a weak androgen drugs that is also known as danazole. So excessive estrogen secretion is one of the problems which is controlled by the use of by the use of follicle stimulating hormone, or you can say by the use of other antagonists. And one of the agent is known as danazole, which is a weak androgen which is used for the management of endometriosis. So this was about point number 10, and point number 11 is about corpus luteum. As you know, corpus luteum mainly secretes progesterone. Point number 11 is about the inhibition of ovulation that is being achieved by the use of combination pill which contain estrogen and progesterone. It actually inhibits the pituitary gonadotrophic release GnRH hormone. This release of that hormone inhibits this complete chain of reaction through which the production of FSH inhibits. So ultimately, ovulation inhibits. So that's why birth control pill contain majorly estrogen and progesterone in combination. There are some other reasons which we'll discuss in point number 14, that why estrogen and progesterone combination pill is mandatory, whereas estrogen alone can produce the same effect. Point number 13 is about the you can say in is about the clomiphene. As you know that it is used for the treatment of infertility, and its dose is recommended 50 mg for 5 days. Similarly, tamoxifen, it is used in primarily in estrogen dependent neoplasia, and it also causes hot flashes. And raloxifene acts as an estrogen in bone and lipids. So these were just introduction of this drug, just a review of about clomifene, tamoxifen, and raloxifene, as we have already talked about this drug in the start of our about our this female reproductive systems points. So this was point number 13, and point number 14 is about the drug regime in for the hormonal replacement therapy and position of progesterone. As you know that postmenopausal effect, whereas the postmenopausal effect shows many other changes in female normal body functioning. Similarly, it also increase the concentration of LDLC, in blood lipid profile. LDLC postmenopausal effect will be more prominent on LDL production, and in that ladies LDL level will increase abnormally than that of other ladies who are not facing this postmenopausal effect. I would like to mention to you for the hormonal replacement therapy in female. There are three approaches. Number one is about the use of estrogen on first 25 days or first 21 days of each month, and the dose of estrogen that is recommended in that case is zero point 0.3 to 1.25 mg per day, and in case of ethinyl estradiol, its dose is recommended 0.01 to 0.02 mg per day. Side by side, it is recommended to use calcium supplement up to 1500 mg. So this is first point approach in which there is no room for progesterone. Only use estrogen alone for first 21 to 25 days. Second approach, but there is a problem that estrogen is associated to increase the risk of endometrial carcinoma. So that's why we need to use progesterone in combination of estrogen, because it reduces the risk of this endometrial carcinoma. So under this case, we got a second approach, that is the use of medroxyprogesterone with a dose of 10 mg per day during last 10 to 14 days, and the dose reduce if pregnancy, but if there is an unwanted effect associated with this progesterone, then we can reduce its dose from 10 mg per day to 2.5 to 5 mg per day for last 10 days. So in this case, in first 10 to 20 days, estrogen alone is recommended. In last 10 to 14 days, progesterone is used in combination with the estrogen. So in third approach, we use estrogen alone for first from day 1 to day 14, or we can say from first 14 days we use estrogen alone, and in last from 15 to 28 days we use combination estrogen and progesterone therapy in a combination. So these are three approaches in which either we can use estrogen alone, or we can use estrogen in combination with progesterone, or we can use estrogen for the first first 14 days, and in combination we use estrogen and progesterone for last 15 days. These three approaches are recommended for hormonal replacement therapy. And just I just like to let you just remind you that if you are facing we are using progesterone for the reduction of risk of estrogen associated carcinoma. Similarly, if unwanted effect is associated with the progesterone, then we will reduce its dose. And if we are using medroxyprogesterone, we will reduce its dose from 10 mg per day to 2.5 mg to between the range of 2.5 mg to 5 mg per day. And this dose reduction will ultimately play a role for removing the unwanted effect related to progesterone. Use of clonidine, if adverse effect is associated with estrogen, then we will use clonidine. And if estrogen is contraindicated, or we can say estrogen or ethinyl estradiol is contraindicated, then we can use clonidine to produce this effect. This was all about a drug regime of progesterone and hormonal replacement therapy and various approaches for the hormonal replacement therapy. Point number 15 is about the minotropin. Minotropin is a drug you use for infertility, and it is a combination of LH and FSH. Point number 16 is about the pemaprome. Pemaprome is an diuretic. It is used in case of postmenstrual syndrome. This was all about the point number 16. And next point is about, as you know, they're commonly used as I mentioned about estrogen. So let's see what are the commonly used estrogen and their examples. We have available ethynyl estradiol. Its dose range is available from its doses are zero point 0.01 to zero point 0.02 mg per day, that is available in preparation form. Similarly, we also have micronized estradiol. Its dose is 1 to 2 mg per day. Similarly, we have estradiol cypionate, and its dose is 2 to 5 mg per day. It is recommended for 3 to 4 weeks. Similarly, we have estradiol valerate. Its dose is 2 to 20 mg. Similarly, we also have estro. As we was talking about the estropipate, and its dose is 1.25 to 2.5 mg, 2.5 mg per day. Similarly, we have some conjugated esterified mixed estrogenic substances, and its oral dose is zero point 0.3 to 1.25 mg per day. Its injectable formulations dose is 0.2 to 2 mg per day, and it is also available in form of transdermal patches. We have some examples like quinastril. Its dose is zero point 0.1 to 2 mg per day. Similarly, chlorotrianisence, its dose is 12 to 25 mg per day. And methalanestril, its dose is 3 to 9 mg per day. So these are the examples of commonly used estrogen. Similarly, we also have progestational agent. So let's discuss their examples. The examples are progesterone, hydroxyprogesterone. These are available in the form of intramuscular formulation, and medroxyprogesterone, it's available in the form of intramuscular as well as oral formulation. And micastrol, it's available in the form of oral formulation. We have 17. We have some derivatives like 17 ethyl testosterone derivative. Its example is the dimethysterone, and we have 19 nor testosterone derivatives. Its examples are desogestrel, northindirone, and lenestrinol and northendirone and northendirone acetate and ethianodiol and levonorgestrels. These are the examples of 19 non-testosterone derivatives. So these are some examples of progestational agents and estrogen, commonly used estrogen agents. So this was almost conclusion of our topic. Now, in next point, we will discuss schematic pathway of hormone and their production in female, their actions and productions and chains in female reproductive system as well as in male reproductive system. So as you know, as I told you in the start of video, that hypothalamus releases GnRH, that is known as gonadotropin releasing hormone, which activates pituitary, which produces in male. So we know we will specifically discuss about relevant to the testosterone. In male, hypothalamus produces GnRH, gonadotropin releasing hormone, and it activates pituitary, which release luteinizing hormone, and in testes it produces or stimulate the production of testosterone, which is converted into the form of dihydrotestosterone, which acts on the receptor and produce effect. So under this change, which we can, if we can control the level of this hormone at the step first from the production, at the point of production of GnRH, that is known as gonadotropin releasing hormone, either we can suppress it or we can activate it by using various intervention. Similarly, at second point, there are some drugs which shows interaction like ketoconazole and spironolactone. These drugs blocks the production of or inhibits the production of testosterone from testes, as luteinizing hormone from the pituitary gland stimulates this production. Ketoconazole and spironolactone blocks this chain. Similarly, at next step, once testosterone is produced, its conversion from testosterone to dihydrotestosterone is blocked by a drug that is known as finasteride. And once dihydrotestosterone is being produced, then its action on the receptor is being inhibited by the use of glutamate and cyproterenone and spironolactone. These are the drug glutamate, cyproterenone, and spironolactone. These drug inhibits or blocks the effect of dihydrotestosterone at the adrenal receptors. So this is a chain of reaction which happens specifically for female reproductive system, sorry, male reproductive system, and for the production of testosterone and their action. So similarly, let's go and review a chain that happens in case of female reproductive system and production of ultimately estrogen and its effect on receptor. Similar thing is that hypothalamus produces gonadotropin releasing hormone in a normal process. It activates pituitary, which release follicle stimulating hormone, and luteinizing hormone, which activates ovary and produces testosterone as well as androstenedione, and it ultimately this androstenedione produces estrone, which is converted into the form of estradiol, and its expression happen at the receptor. So this is a chain in specifically in female reproductive system. So now how we can control this chain? The same in, it's almost same. First step is almost same. We can suppress or we can stimulate the production of GnRH at the hypothalamus, and contraceptive at second step we use contraceptive pills, contraceptives, that is known as one of the example is known as danazol. It inhibits the production of follicle stimulating hormone as well as luteinizing hormone. Or we can also use clomiphene. It actually stimulates the production of follicle stimulating hormone and luteinizing hormone. This step happens at pituitary gland. Let's move on next point, that is known as ovary. Here again, uh, we can say ketoconazole and weak androgen, that is also known as danazole. It inhibits the production of testosterone as well as androstenedione. And at next step, anastrozole is a drug which inhibits the production of testosterone into the estradiol, or inhibit the production of androstenedione into the form in the form of estrone. And this step is being controlled by the use of anastrozole. And in the end, we use once estradiol is the level of estradiol is achieved, its expression at the receptor is being controlled by the selective estrogen receptor modulator drugs. Either it inhibits or increase the production of this selective estrogen receptor modulator, either inhibits this effect of estradiol or stimulates its effect. Similarly, we have one of the example from statin, that is known as fluvastatin. It also inhibits this step. So just for a brief summary, we use weak androgen, that is also known as the danazole, as an contraceptive, which is used to for the inhibition of follicle stimulating and luteinizing hormone at the point of pituitary. Similarly, we have clomiphene citrate, which actually stimulates the production of FSH and LH at the point of pituitary. At the level of ovary, ketoconazole and danazole inhibits its production. So sorry for interruption. As we was talking about fluvastatin, actually it blocks the estradiol for its expression at the receptor. And I was telling you, I will just go and give you a brief review that how we can control the chain of female reproductive system associated hormones. And as I told you about the contraceptive, danazole and clomiphene, which actually stimulates the FSH and LH production. Similarly, ketoconazole and danazole, which actually inhibits the production of testosterone and as well as androstenediol dione. Actually, or in simply you can say it actually inhibits the production of estradiol. And next drug is the anastrozole and fluvastatin and selective estrogen receptor modulator. They act at various chains, as I told you, which ultimately blocks the production of action of estradiol or its expression at receptor. So this was all about a brief review of the chains of hormones that involve in male reproductive system and as well as in a female reproductive system for the production of testosterone and estrogen and their effects. So here our topic ends, and it was just an abstractive study relevant to the estrogen as well as androgen. And now we are going to resume our. In the last, we will discuss about a small steroid producing glands. Its synthetic preparation is also used for some adrenergic deviation, but for adrenergic disorders, we will use specifically for Cushing syndrome and Addison disease. It happens because sometimes due to the hypersecretion of cortisol from adrenal cortex. For example, in case of Cushing syndrome, it is due to excessive secretion of cortisol from adrenal cortex, and the patient show following physiological symptoms once who is suffering from this Cushing syndrome. Its example is the protein loss, trunk obesity, paleotoric phase, muscle wasting, poor wound healing, osteoporosis, mental disturbances, hypotension, and diabetes mellitus. It often happens due to the tumor in adrenal cortex, and which is being surgically removed. And side by side, IV route of hydrocortisone with a dose of 300 mg is recommended for management of this situation. Similarly, in opposite case, in Addison disease, cortisol level secretes less than actually required, or you can say it happens hypofunctioning of cortisol that is released from the adrenal cortex. And in this, due to this hyposecretion of cortisol, patient shows following physiological attribution, that is the bronze pigmentation on skin and progressive anemia, low blood pressure, diarrhea, severe prostration, weakness, fatigue, weight loss, hypotension, hypopigmentation, inability to maintain blood glucose level during fasting. Its acute phase is managed by the use of hydrocortisone with a dose of 100 mg through IV route with a duration of 8 hours, and this treatment should be started within 5 days. Similarly, primary insufficiency is managed by the use of 20 to 30 mg daily dose of hydrocortisone, and this is supplemented by the fludrocortisone. And this is all management of Addison disease and Cushing syndrome were actually opposite to each other. As I told you that this is a small steroid producing hormone. Steroids are very useful in adrenergic disorder as well as for the management of non-adrenergic disorder. So before going to see which non-adrenergic disorder is being managed by the use of steroids, we will discuss some of the examples of steroid. There are three main classes of steroid. First one is the short to medium acting glucocorticoids. Its example are hydrocortisone, its dose is 20 mg per day. Similarly, cortisone, its dose is 25 mg. Prednisolone, its dose is 5 mg. Methylprednisolone, its dose is 4 mg. And dinisone, its dose is 4 mg. And next is the immediate acting glucocorticoid. Its examples are the triamcinolone, its dose is 4 mg, paramethasone, its dose is 4 mg, fluprednisolone for prednisolone, its dose is 1.5 mg, and long acting glucocorticoid, its example are betamethasone 0.6 mg per 0.6 mg and dexamethasone 0.75 mg. There are some examples of mineralocorticoids. That is the fludrocortisone, its dose is 2 mg, and dexocortisone, its dose is 2 mg. And now we will see there are some non-adrenergic disorder which is being managed by the use of glucocorticoids, or the use of glucocorticoid for the management of non-adrenergic disorders. There is a list of disorders, that is the allergic, for the management of allergic reaction, collagen disease, and as I was talking about the non-adrenergic disorder associated with glucocorticoid use, so we can use this drug associated with them, that is known as prednisolone, or usually steroid producing drug for the management of allergic reaction, collagen vascular disease, eye disease, GIT tract, gastrointestinal disease, systemic inflammatory disease, infections, inflammation, inflammatory conditions of bone and joint, especially for nausea, vomiting, neurological disorders, organ transplantation, pulmonary disorder, renal disease, skin disease, and thyroid disorders. So this was all about our adrenal gland. There are some parts remaining, I think. So time of video is going too much. So thank you so much for listening. And if you feel that this effort is helpful for you, then please subscribe our channel, and your subscription would be enough for our appreciation. Thank you so much. Remaining